Thank you so much for joining us and welcome to today's CanCOVID workshop, Mental Health and COVID-19. My name is Katrina Mullaney. I'm an associate professor in community rehabilitation and disability studies in the Cummings School of Medicine at the University of Calgary. I'm the CanCOVID theme lead for psychosocial and behavioral sciences. I'm very pleased to moderate today's important discussion. We have 4 sessions, 5 presenters. Each of the 4 will have 15 minutes to share their presentations, and then we will have about 30 minutes at the end for questions. We're asking you to please post your questions in the chat or raise your hand during the Q&A session, and we'll do our very best to get to as many questions as we can. The topic of mental health personally has been an area of research interest to me for several years, and certainly COVID-19 has had a significant impact on the mental health of Canadians from all walks of life. So I'm very pleased that we have our presenters with us today, all of them working in the space of mental health and all coming from a slightly different perspective. So hopefully we will have a really rich and fulsome discussion today. I'd like to get us started with our first speaker. Thank you all of you for joining today and giving us some time to share your important work. I'll introduce each speaker very briefly before their session. And today we are starting with Dr. Bonnie Lashowitz, who is a colleague of mine here at University of Calgary. Bonnie's project is called Supporting Mental Health and Preventing Moral Injury among long-term care workers, and is focused on understanding and supporting their mental health using the concept of moral injury. So thanks so much for being here, Bonnie, and over to you to get us started.
Thanks very much. Just happy to have this opportunity to converge with others in, as you note, the space of mental health in the context of COVID. I'm sure it's no secret, or it won't surprise anyone to recall that the long-term care sector has been pronouncedly hit by the experience of the pandemic. And so my concentration is on the workforces that serve the long-term care sector. And just to get us started, I wanted to have a short video that I think does a better job than I could do to set the stage for us. So Rosa, if you could please screen share and show that first segment of that video. Thank you.
If I said I'm fine, I think of you at least 100 times. 'Cause in the echo of your voice I hear words just like you. I still come home from a long day. So much to talk about, so much to say. I love to think that we're still making plans in conversations that'll never end. Conversations that'll never end.
Thanks very much for facilitating that. So I'm here today because there have been a lot of public and political sort of debates, headlines, stories, drama, accusations, etc., about the status of the long-term care sector during the pandemic. And I am struck that amidst all of that, there's a workforce that just continues to show up day in and day out. And as most people are quite familiar, the long-term care sector is supporting people who require 24-hour care. There's medical sort of volatility of the people who are served in the sector. And so just thinking about the intensity and the ways in which that has just carried on, including in this new world order generated by the pandemic. So just to kind of highlight, we know that the long-term care sector was hit pronouncedly. 80 to 85% of Canada's deaths occurred and continue to occur in long-term care settings. That puts Canada in a relatively poor ranking among affluent nations. Correspondingly, we heard and experienced some really dramatic sort of action having been taken back in the spring when the pandemic was relatively new. And, at its extreme, the civilian care teams deployed by the Canadian Armed Forces were on the ground and providing sort of emergency support to some long-term care centers in Ontario and Quebec. What this, I hope, will do is provide us an opportunity to really rethink where long-term care sits in the healthcare system. And we know, for example, that we've got a history of not paying very much attention to long-term care as researchers, particularly in relation to emergency preparedness. What we tend to find, when there are outbreaks, we get some sort of epidemiological kind of accounts that provide us with some, basic kind of incidence and prevalence. But beyond that, I think there's so much more to be done for the sector to be treated in the way that it is necessary. Just to background in terms of the population in whom I am interested, the work in long-term care, as I noted, it's intense, it's physically demanding. Often the pay is not high. The opportunities for just to locate this in an intersectional way, particularly using concepts of sex and gender. We know that in excess of 90% of that workforce are female, and many of those workers were born outside of Canada. So we've certainly got some cultural sort of intersects there as well, just to name on which I'm focused. So my work is about taking that intersectional kind of angle on all of this and thinking about the experiences of mental health during the pandemic for this workforce, and paying attention to the social locatedness of the workers in terms of gender and also culture. So the way that I am organizing this work is, as Katrina indicated in the intro, I'm using the concept of moral injury. Moral injury gained purchase in post-Vietnam War years as a way to think about the kinds of traumatic mental health lingering experiences returning soldiers had, and it encompassed elements that fell within the purview of traumatic stress injuries, and yet also had some distinct dimension. So moral injury is a way to concentrate our attention on people's experiences with complex emotions, mostly guilt and shame emotions, and the ways that those experiences accrue because people are in circumstances where there is a right thing that they know that they would like to be doing, that they value, that they know that they should be doing, and yet owing to some constraints beyond their control, they are unable to do those things. And I think this is just a really refreshing kind of take on mental health, because it so expressly casts it in terms of the structures and processes in which individuals are immersed. A structural process-driven kind of concept. I juxtapose that with very individualistic focused concepts like burnout, or like anxiety, or like depression. And if there's a takeaway message on this, the end of life visit, time-wise, they're contained in terms of the numbers of family members or friends who can visit, and those people who do get in to say goodbye, to say a final goodbye to a dying resident, are fully gowned and gloved and masked, and all of those kind of distancing things. Correspondingly, if family members are not permitted to come in, or are finding themselves in a place of acting as conduits, they're holding the telephone to the ear of a person who's near death, and hearing that person's loved ones sort of say their final goodbyes. As if that's not all enough to kind of give this picture. One additional data point that really struck me is that a woman's father died in the early months of COVID, not from COVID, but then that woman was not permitted physical access into the long-term care center. Her mother face to face that her father had passed away. Okay, I'm pretty much going to stop thinking about gender and culture and the ways that COVID intersects with the experiences of workers outside of their work, the anxiety that you can carry into your home life vis-a-vis your family members, just overall kind of juggling and balancing between competing demands. And so that's what moral injury is about. And what we want to do with what we learn about people's mental health needs and their risks, the kinds of things that are causing them to be wanting to create by the end of this. And here are our sort of beginning specs, if you will, on the kinds of components a toolkit would have. But we really want to create something that is portable, accessible, zero to low cost, and a go-to sort of resource for this workforce. Okay, in conclusion, it's high time, it's more than time, care and attention to this, and so on and so forth. And I think all of that tilts our gaze away from the incredible relational work, incredible amount of dedication, and just skill, just plain skill. So I'm taking this as an opportunity to shine light on that incredible skill, and to endeavor to support the workforce that is enacting that skill day in and day out. Quick acknowledgement. I'm really excited. This work has financial support both from CIHR, and also just like a week ago, I got a dovetailing grant from the Ministry of Labor and Immigration at the provincial level, and it's for a call for funding applications called Supporting Psychological Health in First Responders. And I made an argument that the long-term care workforce is a set of very important first responders. On my team, a family caregiver who was quoted on that previous slide, as well as a couple of knowledge user partners who are just absolute champions for the sector and for research and innovation in sector. I've got a investigator from the School of Nursing. And additionally, I can't say enough good things about my PhD trainees, Nick Bocher and Kimberly Manalili. Nick Bocher knows more about online and tools on the go than I will ever hope to know. Kimberly Manalili knows a great deal about implementation science, which is the heading of the CIHR grant, and how to actually organize and deploy a resource into actionable status. So gratitude to my team, and just popping up my contact information. Thanks so much for listening.
Thanks so much, Bonnie. Obviously, really, really important work, and I'm really looking forward to the results as you continue. On our agenda, we have Dr. Jeanette Wagemaker-Schiff. Jeanette is a professor in the Faculty of Social Work, also here at the University of Calgary. Jeanette and I have worked together several times over the years. Her discussion today is about psychosocial homelessness services and organizational responses to the current challenge. So over to you, Jeanette, please go ahead.
Thank you so much, Katrina. Can you see I've put on share screen. Can you see
Not
my
yet.
Screen?
Not
yet.
Yet.
Okay.
There, it's coming up now, Jeanette. Great. We see it.
We're good to go?
You bet.
Thank you so much. I've entitled this to Psychosocial Demands and Traumatic Stress and COVID Responses Among Homeless Sector Workers. And I'm going to quickly go through a little bit of background research that I've done and then trail it into what we're doing in terms of, excuse me, the world of COVID. Oh, wait a minute. I'm not getting this to forward. Okay, somebody is forwarding it for me. Okay, so why do we need to look at the psychosocial need? When I originally started this research about a half a dozen years ago, there was a discussion about pervasive burnout among workers who are providing direct services in the shelters and outreach programs and transitional housing programs in the city of Calgary. And I'm going to come back to this whole issue of burnout in a little while because it's really there was concern about the adequacy of staff training and supports, and also looking at whether or not it was salary or benefits that were related to reportedly high rates of turnout because they're very costly to the organizations. There was also a lack of recognition of work-related mental health stressors that were going on. And we thought at the time that traumatization might be an important factor to consider. So rather than just looking at burnout, were we looking at secondary traumatic stress, or more importantly, were we also looking at primary traumatic stress? And then what prompted the current work that I'm doing is to look at whether COVID exposure and precautions may be adding significantly to this burden. So in the prior work, and this is primarily quantitative studies, we did surveys with frontline workers. 95% report at least one major, I call it a life stressor, or a significant event that could precipitate a traumatic stress reaction. And over 55% reported that one or more of those traumatic events happen at work, so that we already begin to establish a baseline for workers having a vulnerability to traumatic stressors both in their lives and at work that we needed to really pay attention to. So in those early reports, what we found is between 33 and 41% of all staff reported traumatic stress, not burnout, but traumatic stress at a level that would qualify for a diagnosis of acute stress disorder In contrast to that, 24% of staff reported secondary traumatic stress and 25% reported burnout. So, what we were hearing from staff is that they were more stressed out than they were burned out. Not that the two don't coexist, they do, and they have some high correlations. But the is significant direct traumatic stress, they were reporting extremely high, alarmingly high levels. So, how do I distinguish the issue between burnout and traumatic stress? Burnout, actually, as we looked at our data, is highly correlated with reduced compassion satisfaction. And by compassion satisfaction, we're really talking about the pleasure, the inherent value that people get out of working and trying to help others. In burnout, that is markedly diminished. In traumatic stress, it's a little bit diminished, but far less so. So that people continue to care, but they're feeling very emotionally and physically worn out and stressed. The other thing that I would ask you to note from these two graphics is that burnout is like the embers of the fire going out. You're too depleted to or stress, very emotionally and physically depleted as a result. So there is a real qualitative difference. And the reason that that's important is that the inter are feeling traumatically stressed are not entirely the same as those that we would use for burnout. In fact, some of them are quite different. So I have here in this chart, and I'll just refer to it very briefly, is the differences between what we've identified as acute traumatic stress and PTSD symptoms and burnout. So that in burnout, you've got the physical and emotional depletion, whereas in acute traumatic stress, you're more likely to see symptoms of intrusion, avoidance, and arousal. So the intrusion and arousal symptoms are not going to show up in burnout for staff. In burnout, you're going to find frustration, whereas in stress, you're going to find anxiety. In burnout, there's a lot of anger as opposed to the fear that you find in traumatic stress. Both have elements of depression. So, again, we're not looking at concepts that are mutually exclusive. Whereas in burnout, you're going to see a reduced response to clients and to coworkers. Whereas in traumatic stress, you're going to see avoidance. Now, the reduced response can look like avoidance, but their dynamics are different. You're going to find in burnout a sense of depersonalization, a really kind of a dimming of the emotional and physical lights. Whereas in traumatic stress, people are going to often talk about intrusive reminders of things that have been upsetting. And when it comes to frontline workers, we're talking about a number of different kinds of upsetting events that can occur in the course of work. I will fast forward in a minute to how this relates to COVID, where we found that the intrusion involves a number of elements that are part of the traumatic response. There are sleep difficulties and appetite difficulties for both. Feelings of accomplishment where they still feel that they're doing a good job, but they're just getting depleted from trying to do it. And in traumatic stress, there may also be alterations in a person. It almost in some ways relates to the moral injury that Bonnie was talking about with her work, um, where there are issues around intimacy and trust and that really get into that moral sphere. Whereas in burnout, you're going to feel more feelings of loss of role, identity, and importantly, more in terms of a loss of idealism. So anyway, what we came up with was a trauma-informed care mediation model. This was on our earlier work, and we expect to see this going forward, where that organizations and these pathways differ. Because if the organization employees in trauma-informed care, you're going to have an increase in physical safety, and you're going to have a reduction in trauma symptoms, but it's going few. We think that within COVID, this pathway may change, and that's what the current work is all about. So in the prior work, we saw that the some of the things, the outcomes that came out of this private work, inclusion of frontline workers in the homeless sector as a group impacted by PTSD in 2017 for PTSD Awareness Day. The implication of this is that in calls for work going forward and research studies that now look at frontline workers, the homeless sector is automatically included. Um, Statistics Canada developed at the request of HRDC a profile of frontline workers into, and actually their profile pretty well lines up with the profile that we had developed. So we got some pretty strong outcomes coming out of this. The frontline workers were included in research calls in 2019 and now again in Alberta. And the other thing that's become important is that frontline workers are becoming recognized by workers' compensation boards as being vulnerable to psychological injury on the job. So the whole idea of psychological injury and how that plays out in working with vulnerable populations is extremely important. Okay. Well, first of all, if you saw, you remember back to the we talked about physical and psychological safety. Those safety mechanisms don't exist in the same way during COVID. We want to explore whether that change in or reduction in physical and psychological safety, the extent to which this is having an impact on staff. Whether or not it's the available of PPE, personal protective equipment, and fear of contagion is driving some of these responses. What kinds of client crises are going on? We know that in the homeless sector, concomitant or at the same time that we're having these outbreaks of virus in shelters, which is creating huge stressors in the shelters. We're also having an opioid crisis, and where there's been a real spike in opioid overdoses, and this is creating an additional stress on staff. The inability of staff to work from home, so that there are the opportunity to work at a distance. For many frontline workers, that is not optional. To what extent is those workers who can do at least part of their work at a distance, such as case managers, etc., who can do telephone appointments, video calls, meet clients at a distance, to what extent are they doing better than those workers who are working in the shelters and interacting with clients 24/7? The lack of adequate time off to recover both from going on at the workplace, and also to be able to cover COVID related requests to quarantine. Um, the We know that frontline workers have a critical role in ensuring the safety of extremely vulnerable people. And we see homeless people as having very high, first of all, very high transmission rates. And they also have, we know from prior research, very high physical and mental health vulnerabilities. There's a lack of adequate supervisory reports that we found in previous research. To what extent are we still looking at the lack of supervisory reports? And to what extent is loss of income due to illness also a predictor for staff well-being? So the key questions that we're asking, and so this study, as in Bonnie's study, I've been funded by CAH acts of COVID on frontline workers, and we're going to be able to compare that with the data from the previous study where we had baseline data on how well workers were doing. But we want to ask is to what extent do staff report traumatic stress and or burnout, and how has the pandemic affected this stress? Is it attributable to work related experiences or prior experiences or both? And what supports and practices can reduce this impact? So we also want to examine what kinds of interventions may be helpful in terms of staff training, organizational supports, compensation, other benefits, or what kinds of self-care practices can staff be helped to access in order to lessen their burden. We're using a survey. We're doing this survey in 7 cities across Canada: Edmonton, Calgary, Thunder Bay, Toronto, Fredericton, Moncton, and St. John in New Brunswick. And we're looking at the professional quality of life in order to look at secondary traumatic stress and burnout. We're looking at primary traumatic stress by using the PCL to screen for trauma, life events and adverse childhood experiences to determine whether, to what extent, the staff is vulnerable coming into this work. We're also asking questions about organizational supports, personal coping strategy, and life experiences and supports for Indigenous staff. And some of you may say, where did the Indigenous piece come in? Several years ago, when this was done within the domestic violence shelters within Calgary, one of the local Indigenous agencies said that they would only participate if we had questions that were specific and salient to their staff. So we developed those. And in doing the current round, we were asked by some of the providers in cities outside of Calgary to include the Indigenous questions because they had significant numbers of Indigenous staff on board, and they wanted to know if they were more vulnerable or if they needed other and specific supports in order to help them to cope. So moving forward, what we're doing is we're surveying the staff. We're also interviewing senior managers to understand the coping strategies that organizations have adopted. And we're just in the process of analyzing that data. It's just to give you a quick heads up. It looks from a preliminary basis and supports for staff. There's also some organizations have been able to receive some additional funding for staff training and supports, but it's not clear how much of that is really flowing down to the front line. We want to understand which stressors and supports have the greatest impact, both positively and negatively. And then we want to look at knowledge translation to ensure that results are brought to the attention of health services, community, provincial, and federal legislatures. So we've got a knowledge translation team that consists of 2 senior leaders from Alberta Health Services, a knowledge translation person who is located at a Fred Victor, which is a major shelter in Toronto, and then a knowledge translator out in New Brunswick, who coordinates many of social agencies out in New Brunswick. So we want to be able to get the information about what we're doing out to the widest number of people. So the other thing that's important within this research is that when you're looking at broad-based surveys like this, most of the work that has been done, especially on secondary traumatic stress and burnout, relies on convenience samples that most often have a response rate of 35% or less. And some response rates are really much lower than that. The organizations to participate. And in doing so, we said, if you're going to participate, please make your staff available to complete a survey either online or by paper based during working hours. And we say online or by paper-based. This is a modification due to COVID because our researchers cannot go in and meet directly with staff to do this survey. We requested time at staff meetings to explain the survey, distribute it, provide time to answer some questions, ask people to complete it during the workday, return it to us. And we relied on this work time participation to really increase our response rate. I must say that in the prior resulted in between 85% and 100% of all staff participating. During COVID, we're finding the response rate is lower. And that may be due to the whole way in which this research request has to be done more at a distance. We were doing it face-to-face in person. It seemed to get a more immediate and more widespread buy-in. That being said, the other thing that we know is that many of these and they're not able to participate in the same way. So that this is another learning that we have. We're using the interviews with the key administrators to understand the implementation. Oh, there's a typo there. Ignore it. Of supports for staff during the pandemic. And so what are the lessons that we're learning from this? Wait a minute. Got it with me. Oh, I've still got plenty of time. Okay, so the lessons to be learned from the pandemic. I think that we're learning lessons about the threats, the lack of recognition of the vital role of frontline workers, the fact that frontline workers were not considered as part of the original work pool that would be eligible for vaccine shots as they were being rolled out. That in a number of jurisdictions has now changed, but the workers who are really certainly the ones who are providing direct care to people who either have or are most likely to be vulnerable to the virus, hospitals, long-term care facilities, and then the homeless shelters. There's a lack of mental health and addictions training for managers and staff. So we're finding as we go across the country that the original studies that we did that indicated a real lack of education and training for people working in the sectors is being in the times of COVID where staff are they're not accessing additional training and supports that they need. And there certainly is a real inconsistent use of trauma-informed care. In fact, in a lot of places, people are really not clear what that means or what kind of impact that could have on the well-being of staff and clients. What are our opportunities with this? Well, one of the opportunities is that we can influence federal and provincial policies aimed at staff support, realizing that if the staff, which is the vehicle for service delivery, is not adequately supported and trained, they're not going to be able to do an effective or an efficient job. That we're going to have to identify increased training and relevant education for staff. We're going to have to provide multiple and diverse supports, that the same supports are not going to be versatile with that, and that we have to implement a trauma-informed care at all levels of the organization. In other words, to begin to get the message to administration as well as to frontline staff that they all have to be working in consort. And I think that comes basically to the end of my presentation on this. So as I said, I hope within the next few months that we're going to be able to take this a little further. Just one final thing, because I have a couple of minutes left, right, Katrina? I want to go back to the burnout thing for a minute, because I think it's really important. When I first started this work, as you saw your screen, so that we can move forward.
Thanks so much, Jeanette. Okay. Thanks so much. There's obviously unique stressors in a situation like this. There's often exacerbated by limitations in social distancing and sometimes days and days of work without a day off for staff. So really important work. Thanks so much for sharing. Next, we have, very happy to welcome Dr. Brianna Turner and Dr. Fiona Patterson from the Department of Psychology at the University of Victoria. Their team is leading 3 national surveys regarding the mental health impacts during the COVID-19 pandemic, specific to 3 phases in the pandemic: fall 2020, winter 2020-2021, and now moving into spring 2021 as well. So welcome to both of you. Please go ahead and start your presentation.
Thanks very much, Katrina, for the welcome. So I'm Brianna Turner. I don't know if Fiona, if you want to say a quick word so your video shows up and people can see your face.
Hi, I'm Fiona Patterson.
There we go. We'll both be speaking to you today and really appreciate the opportunity. Coming to you from Victoria, I want to start off by briefly acknowledging with respect the Lekwungen people on whose traditional territory the university stands, and the Songhees, the Esquimalt, and Wasanich people whose historical relationships continue with the land to this day. As Katrina mentioned, we're going to be talking about a series of surveys that we're conducting across the general Canadian population, and focusing today on some of the results and what we're learning about the mental health impacts of the COVID pandemic across the lifespan. So I'll start off by giving a general sense of the scope of our research project as it relates to COVID and mental health. So we have been fortunate, like the other researchers who've spoken today, to have received funding from the Canadian Institutes of Health Research, as well as the Michael Smith Foundation for Health Research here in BC. And our overall project has sort of 2 main components. So one of our project components is a general population survey where we're recruiting Canadians from online survey panels as well as through social media to complete a roughly 15-minute survey assessing mental health concerns, things such as depression, anxiety, trauma symptoms, other mental health concerns across 3 different phases of the pandemic. So we did our first survey in the early fall. Our second survey happened in winter. We're just wrapping that one up now. And we're planning a third survey in the summer. And so we're hoping to kind of see how mental health impacts have evolved at these different periods of time. One of the unique features of those general population surveys is that they are being coordinated with surveys within participating countries. So we will also have an opportunity in Canada relative to other countries that may have unique outbreak dynamics, unique mental health systems, unique mental health supports, et cetera. The second kind of component of our work is going to be some targeted surveys that we're co-creating with a group of patient partners as well as knowledge users, including mental health service providers and policymakers, for 3 priority groups. So we'll be looking specifically at the mental health impacts for people who are living in rural and remote communities in Canada, for Indigenous people in Canada, as well as for healthcare workers. And we anticipate that those surveys, because they are being kind of co-created with people from each of those different stakeholder groups and communities, will likely slightly different methods, more likely a kind of mixed methods approach with some qualitative and quantitative pieces. So we'll be rolling those out in the spring and summer. So the general population survey, first 2 waves, the targeted surveys are planned for the future. Because this is a work in progress, I've popped the link to our website where we'll be posting results as they become available just at the bottom of this slide. So if anyone is interested in updates, that's probably the best place to go. So for today's presentation, we're going to be focusing on those general population that we've completed. So this slide gives an overview of sort of the samples from each of our first 2 wave surveys. So our wave 1 survey had over 6 respondents from across Canada. It was completed between mid-August and the end of September. And you can see in blue are the numbers per province of respondents that we received. The graphs along each side show sort of the demographic breakdown of the sample. So our sample skews slightly female. We have relatively even and representative numbers of participants coming from various age groups. And our sample does also skew toward white, people who identify as white, about 70 to 80% of the sample identifying as white in each of our waves. The second wave survey had a slightly smaller number of respondents, of 500. That was completed over the holidays, so beginning a few days before Christmas, December 21st, and we're just coming in. But the goal of these surveys, again, was to get a representational group of Canadians enrolled and reporting about how the pandemic has impacted their mental health. Oh, the other thing I should mention, we did complete the survey in both official languages, and about 10% of the sample responded in French in the first wave and about 15% in the second wave. So looking at some of the indicators of mental health across different age groups and across the lifespan to try and identify particular segments of the Canadian population who may be differentially impacted. I'll walk through this slide because I know there's a lot of information here. So graphs are displaying on the left is depression and on the right is anxiety. The pale blue lines mark off the different segments of the scale or the score range that indicate either minimal, mild, or moderate level of symptoms. And then across the bottom, you'll see the different age groups. So the first is under 21, the second is 21 to 24 years old, 25 to 34, 35 to 44, 45 to 54, 55 to 64, and 65 and older is how the graph proceeds in case it's hard to see on your screen. The blue line, the red bars would be from wave 2, and that's consistent across the slides. So generally, the pattern that we're seeing across both waves of the surveys that we've completed so far is that our young Canadians are reporting the most severe mental health concerns, in some cases, on average, scoring at least in the mild to moderate range of symptoms on depression and anxiety. And that's, again, that's consistent across both waves of the survey, although we are seeing a slight trend for the younger Canadians to report slightly improved mental health symptoms in the second wave, whereas in some cases we're seeing a slightly opposite trend in the second wave relative to the first wave survey for Canadians who were 55 and older. I've also presented the percent of respondents who scored in the severe range on this scale. The largest percentage of people who are scoring in the severe range tends to be in our younger age groups. Experiencing suicidal thoughts, that's at the very bottom of the slide. And we are seeing markedly higher rates of endorsement of suicidal ideation now relative to previous Canadian surveys that were completed before the pandemic. So typically we see between 3 and 5% of the population endorsing recent suicidal thoughts. And in our surveys, we've seen at least 2% in all age groups, but in many age groups, the rates are at least doubled from where they were before the pandemic. A second component that we've looked at are sort of specific experiences of traumatic symptoms, loneliness and isolation, as well as COVID-related fear. So our COVID, well, I'll start with the trauma. Again, the pale blue lines indicate the spot on the scale where we're starting to score as indicating potentially clinically significant concerns. So you can see for trauma symptoms, again, the young Canadians have the highest scores, and they tend to be the ones who are scoring at or above that clinical threshold. Similarly, from the right here is showing, we asked a question about how people thought that the COVID-19 pandemic had impacted their mental health. So red is a proportion who said that their mental health worsened. Yellow is the proportion who said that their mental health has probably stayed about the same. And green is the proportion of respondents who said that they thought that their mental health had improved slightly since the pandemic began. These don't add up to 100% because we did give people the option to say that they weren't sure or that they preferred not to answer that question. That was available for nearly all of the questions in the survey. And so generally what we're seeing here is, although In our young Canadians, there is probably a slightly larger percentage who say that their mental health has improved. There's also a larger percentage who say that their mental health has worsened. Whereas for older Canadians, the kind of modal response is that they feel like their mental health has stayed roughly the same since the pandemic began. So we've been examining this data as quickly as possible to try and identify some of the different risk factors that may be contributing to greater mental health impacts in young Canadians in particular, as well as different psychological, behavioral, social features that contribute to resilience. So looking first at the risk and some of the different reasons why we may be seeing higher mental health concerns in young Canadians. So one thing, as I've already mentioned, is that young Canadians were much more likely to have a pre-existing mental health condition. And this is consistent with literature that shows a fairly large generational difference in Canadians in terms of how they perceive their mental health, as well as the number of mental health concerns that they have. So those tend to be concentrated in younger Canadians, and that could be one explanation. Moreover, we know that among the younger Canadians under the age of 35, of those who are receiving mental health support, they were more likely to report that those supports that they were receiving were inadequate or weren't meeting their needs. We also see that younger Canadians under the age of 35 had more concern about the economic impacts, and particularly the personal economic impacts of the pandemic. So they were more likely to have lost their job since the pandemic began, or be worried about losing their job. And they also reported greater financial stress relative to Canadians who were over the age of 35. And then the last aspect that we've been looking at is social connection. And when we look at our younger Canadians, we found that they were actually more likely to live in larger households of 3 or more people. But despite living in larger households, they had less close social support. So we asked a number of items about, do you have somebody that you could talk to if you have a problem? How much do you feel like there's a special someone who really cares about you and wants to support you? And Canadians under the age of 35 scored significantly lower on some of those measures of close social support. So it seems like although they have access to equivalent or maybe slightly higher quantity of daily social support, the quality of that social support is rated lower in this group. And finally, in the Canadians under 35, they reported a lower sense of control across events in the pandemic, and also less coping self-efficacy. So they rated themselves as being less able to cope or less confident in their coping skills. And then finally, looking at what contributes to resilience. So across all of our age groups and respondents, we looked at what was associated with people who were generally faring well, who reported that their mental health was staying the same or improving, or who seemed to be exhibiting resilience in the face of the pandemic. And so across age groups, some of the features that are associated with resilience are higher coping self-efficacy, having a more internal locus of control, so believing that that you have more control over events that happen, as well as how you cope with those events, having a greater confidence in your ability to cope and to assist other people that are important to you in coping, being in a romantic relationship or romantically partnered, and especially if you're rating that quality of that romantic relationship positively, tends to be associated with greater resilience. Spending less time on social media and consuming less news media was also associated with more positive mental health. And finally, perceiving a higher level of social support across different forms of social support was associated with resilience. So next, we asked a number of open-ended questions as well for people to describe how their mental health had been impacted by the pandemic. And I'm going to turn it over to Fiona, who will talk a little bit about some of these results.
Right. Yeah. So I'll be pretty quick because I don't think we have a ton of time left. But yeah, so we asked a few questions, and I'm just going to report a little bit on 3 of them. And this is just first blush themes that came across when we were looking through. So we asked, how has your mental health worsened since the beginning of the pandemic? And for younger adults, many more younger adults than older adults completed this item, just observationally. But for younger adults, some of the themes included a loss of normal life, a loss of social life, pressures of either higher workloads and being potentially at risk while at work or losing employment, loneliness and social isolation, and also significant uncertainty about the future, both in relation to life aspects, relationships, dating, things along those lines, as well as finances came up quite frequently as well. For older adults, there were fewer who completed this item, and the themes for some were similar, but others were quite a bit different as well. So loneliness and social isolation came up for older adults too. However, we saw a lot more about recent losses of loved ones and kind of related to adjustment in relation to that. As well as challenges in caregiving were quite prominent, and worries about the impacts of others not following restrictions. So worries and fears about being out in the world with others. In terms of how mental health has improved, and this is focusing on the wave 2 data specifically, for younger adults, themes included things like working from home actually potentially being helpful, maybe less stressful than going into work. Decreased pressure to socialize was helpful to some people, and less stress being associated with there being less to do in general. Also, there was a kind of some people who were saying that they were kind of adjusting to a new way of living at this point. So this is kind of by December, as well as there were hopes related to the vaccine that had come out, and an increased focus on working on oneself and self-reflection was also a theme for younger folks. For older adults, we had decreased, themes included decreased commitments leading to less stress. So working from home was positive in relation to more control over work hours and life in general. Having more time to enjoy one's home and garden, things along those lines. Some also noted having gotten used to isolation and used to technology and using technology to communicate. And also taking on volunteer roles in the community was noted by quite a few people as well. In relation to what both younger and older adults thought might be possible to improve mental health for people, many younger adults, well, there were a few prominent themes that kind of popped up. The most stated idea was that there should be free or lower cost mental health services, much more available to people in Canada. In relation to this, many also noted a need or an interest in having messaging or chat room based mental health services so that they could be accessed without other family members overhearing, which does make sense with younger people living with more people in their households. And others also noted a need for more in-person services, as well as a need for more telehealth video-based, Zoom-based type services. Also in relation to mental health, there were quite a few people that kind of touched on the idea of mental health needing to be better integrated into the healthcare system, more prominent focus on mental health as well as physical health and availability, wait times, cost coverage for mental health services. And then another prominent theme was financial support and security. And there were quite a few people that discussed the idea of basic universal income and things along those lines. For older adults, the themes also focused on increasing mental health services. That was there for sure. But there was also quite a bit of focus on self-strength and resilience. So many people noted that they felt they were not in need of additional supports and that they were doing well. There was also some focus on improving access to physical health services among older adults. So things like better access to general practitioners, better continuity of care for physical health services. And also a need for more clarity from local government about restrictions, number of cases in their areas, and things like that. And then many also just suggested kind of more assistance and focus for individuals who are living alone. So with daily activities, groceries, things like that, as well as with decreasing isolation. So those were the kind of main themes that people came up with for those questions. And I'll just we'll end off with a slide of our wonderful team. So we've got a slew of RAs helping us out, both graduate and undergraduate. And we do have some collaborators to mention as well. Karen Kobayashi at UVic, Chris Lalonde at UVic, and Rochelle Ashcroft at University of Toronto as well as some community partners, the Ontario Association of Social Workers, United Way of the Lower Mainland, and CMHA in Toronto and York Region. Yeah, so thank you very much. Bree, I don't know if there was anything else you wanted to quickly mention.
No, I think that's it for us, and we'll look forward to questions toward the end, I think. Thank you.
Thanks very much, Brianna and Theoni. Really interesting results. There's a few comments and questions in the chat box that we will circle back to. And please, just a reminder, if you do have a question, please pop it in there. Hopefully we have a few minutes at the end today. We have one final presentation today, discussing results from data on the state of mental health of Canadians over a 2-year period starting in April 2020. I'm very happy to introduce Michael Cooper, who is the Director of Development and Strategic Partnerships at Mental Health Research in Canada. So welcome, Mr. Cooper.
Yes, thank you. Thank you for all the presenters to date. I found the last presentation particularly interesting because the findings are very similar to ours. I think it would be great if we could find a way to collaborate and fill in some gaps. So as was indicated, we've been working on collecting data on the state of mental health since April 2020. That was our first data collection. We are funded to continue to do this work until March 2022. Our methodology is we're working with Ledge Opinion, a few other partners, and we are collecting a controlled sample of 2,500 Canadians. And then we're also working with a number of provincial agencies who are funding up samples. So our sample goes anywhere from 2,500 to 4,000. It's collected every 6 to 8 weeks. It's approximately 14 to 16 minutes long. And the best thing about our data is thanks to our partnership with Health Canada, after a short window, which our internal partners work on it, we are authorized to freely make the data available to any researchers who are interested in analyzing it going forward. So I'll just get started. So this is our fifth one. This is the first time I presented this data. We just turned it over 2 days ago. I'm doing a webinar on this, which will be much less rushed than this on Thursday if anyone wants to join. So this is our data from poll 5 of 13 that we're doing. This data runs from February 1st to February 8th, 2021. There's just some methodology around this. So our first sort of bread and butter question is we ask people, what was your level of anxiety before COVID and what was your level of anxiety now, as well as depression? So we found people were indicating their level of anxiety. The number of people indicating high anxiety was about 5% to 7% in the pre-results, moving to 25% today, and 17% depression. 17% of Canadians are actually indicating that they have high depression currently. We've also noted that it is, again, similar to the previous findings, skews younger, and it also skews female. Although the one caveat I would add on that is that we run the Kessler Psychological Distress Scale, and we have noted that the gender imbalance does even out a little more when you're looking at the most severe category on the psychological distress scale. We have multiple indicators. So we've been working on building an index, which has 4 indicators of mental health. And when we filter all that out, it's about 6% of the population has indicated all 4 indicators which we're concerned about, which would be about 1.8 million Canadians. We also ask a number of questions about positive things you're doing or negative things that might be affecting your mental health. Consistently, we found that being outside has people are indicating is the most positive thing they're doing for their mental health. And it was mentioned before, social media is one of the most negative things that people are doing in terms of their mental health. And again, we ask what sort of indicators are you seeing in terms of what's having a negative indicator. We've actually seen the economy and concerns around economic concerns being the #1 driver of negative mental health. We have also seen, though, a continued increase in social isolation, which has just been on a slow progressive curve, getting worse each time we run this. Yeah, I'll just go on. So I'll skim through some of this to give you a sense of what we have. So we asked for a previous diagnosis. I'm certainly surprised to find that a number of people are indicating that they've recently received a diagnosis. We also ask if they've got a diagnosis in their family as a means to control whether or not they're familiar with the mental health system as one control. similar to some of the findings we found earlier, we did actually find the number of frontline healthcare workers indicated that they had had a previous diagnosis. And what's fascinating about some of that work is we also see that they generally score higher on some of the resiliency as well, which is fascinating. We do ask about multiple employment level questions in terms of are you employed, student, retired, et cetera, part-time, full-time, and we ask what sort of situation has occurred since COVID. Your hours have increased, your hours have decreased, you're working irregular hours, you've been laid off and rehired. So there's been multiple ways we can look at that. And then we have about 26 employment categories we look at. Frontline healthcare workers would be one, teachers, manufacturing, first responders. There's about 26 different employment categories that we actually track on an ongoing basis. When did you receive treatment? When was the last time you received treatment? What treatment were you receiving? This is the scale that tracks since April 2020, the increase in anxiety. Our margin of error on this is about 2%. So although each specific instance is generally close or within that margin of error, there's a definitive upward trend of people indicating, the number of people indicating anxiety and depression. Again, we've shown that there are significant numbers of younger people in there, especially parents as well. We've noticed parents of kids who have younger kids under the age of 9. One of the things we ask about is family situations. So we know if they have kids, we know the age of their kids. We also would know if they're, for example, young people living at home. We have noticed that especially young people living at home have a specific negative inference compared to young people who might be out on their own, which is an interesting one we found. We also looked by province. This is the Kessler Psychological Distress Scale. So you can actually see what sort of symptoms these individuals are having. We generally find about 60 to 65% of people who are self-rating on high anxiety and depression, when you provide them this test, show up as moderate to severe on this scale. We also have been asking some questions around how often they're experiencing symptoms. Certainly is surprising to find that 49% of Canadians have said they're either recently or often feeling anxious, restless, or uneasy. Sorry, I missed one here. No, I didn't. We also ask a forward-looking question as a means of hope. You know, how do you think your mental health is going to be in 2 months? With a number of people indicating, only 18% the last one indicated their anxiety would be high. Of course, that is considerably lower than the 25% who indicated that their anxiety is high now. Interesting for me, though, is the depression number now is pretty much on par with where people are expecting their depression is going to be in 2 months. Again, by province. We do have baseline questions that we ask across all of our polls. On some of them, we do ask control questions that are pertinent at that exact time. So we do, for example, we've asked around vaccine hesitancy, we've asked around COVID proximity. It's not in this deck because it was just too long, but we did ask whether there have been exposed or know someone who's exposed, or about 20 different categories of possible exposure to COVID-19. This particular poll, though, we did ask about seasonal affective disorder because we knew we were asking it in February and we wanted to get something that would allow us to control for that. How do you manage your mental health? Again, this is the sort of questions we ask, whether it's a positive or negative impact on your mental health. As you can see, social isolation has continued to move from 41% to 51%. What's particularly fascinating for me here as well is that early on, we found a lot of things were actually having a positive impact. But right around the time we hit poll 2, a lot of those things that were having a positive impact started moving decidedly negative. You can see, for example, communicating with friends or family was 40% positive in poll 1, which was April. But by the time we hit August, it had only hit 18% positive. To us, that indicated that a lot of those things that we were doing to distract ourselves from the early stages of the pandemic and the lockdown were becoming less effective over time. Again, these are some of the economic indicators that we looked at. We do control, as I said, for employment status, so we can look specifically at those individuals who have lost their job. Also, these are again the activity that people might be doing, 11% indicated it's a positive impact on their mental health, versus 43% who indicated that it was being outside was positive. We look at resiliency. So this is our resiliency question. How do you rate your ability to manage and bounce back from challenges and unexpected troubles? The good news that we pull out of this is that it's been relatively consistent that around 60 to 65% of Canadians have indicated they still feel resilient, which is really good. For one control, we look at compliance with COVID-19 guidelines. Not in this particular poll because it's not a large enough sample, but in previous polls where we've had a larger sample here, we have actually correlated high degrees of people indicating depression with lack of adherence to COVID-19 guidelines. There's another one that I pulled out here for length, looking at vaccine hesitancy and the correlation with mental health. Again, there's an employment question in here in terms of how your work's been affected. In the poll prior to this, we also worked with workplace strategies for mental health, and we asked about what resources were really effective by employers. Are you worried about your finances? That's a control question. What supports were you accessing prior to the pandemic, and what supports are you accessing now, or do you think you should be accessing supports? We also asked what sort of supports individuals would be looking for. And then we also created a subgroup of people with high anxiety, the highest or high depression on the self-rated scale, and we look at what activities they're specifically interested in. So if anyone has any questions on this, again, I've got a webinar on Thursday where I'll deep dive into more on this. If anyone wants to join, I can throw the registration link in the comments. My name is Michael Cooper. I oversee this project. My email is mcooper@mhrc.ca. If you're interested in accessing the data, we can talk about it. I'm trying to think if there's anything else I'm missing here. We're really proud to work with a number of partners as well, including 5 research organizations in the provinces, Wellness Together Canada, Health Canada, and a number of other partners who have helped us put this together. So I'm happy to take questions. Thank you.
Thank you so much, Michael, and thanks to all of our presenters today. This is obviously a really important issue, and I am very appreciative of being able to see some data supporting some of the things I think a lot of us have known anecdotally about the impact of the pandemic on our mental health. So thank you again. We do have a few minutes for some questions. I noticed that there have been some contributions in the chat box, so I'm just going to go to the top of the list. And I think probably this first question, it's a bit of a debate that maybe Brianna and Theone would like to contribute to around the differences between younger participants and older participants. There was a back and forth here. Is it possible that younger individuals are more likely to admit, accept, disclose their mental health condition? And another comment related to that by Roy Gillis. Yes, I think it's a factor to consider. Very interesting results. However, the financial stressors mentioned and other social determinants of mental health need to be examined here for a full explanation of the findings. Brianna and Theone, did you want to comment on that and those 2 comments or questions?
Sure, I could say that I think it's possible, indeed likely, that younger individuals are more likely to admit, accept, disclose mental health conditions. We, as I mentioned, we do have studies even before COVID that show this sort of generational shift in how people experience and describe their mental health, with greater awareness and willingness to talk about mental health concerns in younger cohorts. So I think that's likely part of the trend that we're seeing. I also agree that financial stressors and other social determinants of health, that's something that we've been adding additional questions to. In wave 2, we asked a little bit more information about sort of financial situation of our respondents, and we'll continue to explore that in our upcoming survey as well. So I would just say yes to both. Theone, I don't know if you have anything to add, or Michael, if there's anything that you were finding in your surveys that might help to.
Yeah, I don't think I have anything specific really to add, except that looking at the qualitative responses for the older adults, it was pretty clear that there seems to be a difference of perception more so than maybe admitting something, I think, because a lot of the older adults were actually reporting that they feel that.
for my answer on this, I would say that I agree. It's very difficult to ascertain how much is a lack of stigma and preparation of talking about it. I would add that one of the things we specifically looked at were the Kessler 10 for that reason, so we could understand if there was a difference in people indicating levels of symptoms of mental distress, as a way of trying to bypass that sort of stigma question. And we did determine the young people were reporting higher degrees of symptoms, even if they weren't indicating on the self-rated scale that they were struggling. So there is some absolute mental health challenges happening to youth, irrespective of the stigma. How much of the difference between the two groups is one or the other is an open question.
Mm-hmm. Thank you. Thanks to all three of you for that. This is a similar question. I've seen a few people asking about accessing the data. And I think, again, Fiona and Brianna, this came up during your presentation. Would we be able to access this data anywhere? There are some similar studies taking place at Vancouver General Hospital. So I know Michael had mentioned he would include a link for more detail on a presentation he's doing Thursday. And I know this session is being recorded, but are there other ways to access your data, other presentations or places that this data is available?
So I was reading the chat or trying to keep up with the chat, and it's really exciting to hear how many people are saying that there are similar surveys that they're aware of. I think that there's potentially a lot of synergy to be gained if we can kind of combine these sources of data and look at patterns or explanations that might be possible in one data set versus another. So I really appreciate some of the suggestions that were in the chat. So I'll pop in the chat, I'll put our survey or study website where we're, so far we've been posting infographics that our research assistants have been developing that summarize kind of the key themes and findings. The data itself, I believe, will also be released, but we're coordinating with the team in the UK since they are also kind of overseeing and leading the larger cross-national surveys that we're participating in. So the data disclosure, I think, will be made through their repository, but I would be happy, we'll post that on our website when it becomes available if people are looking for direct data access. And I will also put my email address if somebody would like to ask about further data access.
Thank you. Michael, go ahead.
Just to say, I've put the link where our report is into the chat. If anyone wants to download any of the 5 reports we've already issued. I'm just waiting on my lawyer, our organization's lawyer, to sign off on our data sharing agreement. And we have a number of internal partners who get a small window to look at it, 3 to 4 weeks, and then we'll release it. And then we'll be happy to release it to anyone who will sign that waiver, which is anyone who's attached to a university wouldn't be challenging at all. It's protection of privacy and so on and so forth. But we're probably 2 weeks away from being able to share data.
Great, thank you. And I wonder if all of our presenters, Bonnie and Jeanette as well, if you wouldn't mind sharing your emails in the chat box in case folks want to follow up. I know your studies are ongoing and you will have findings moving down the road. So if you're okay with that, that'd be great if you could share your email addresses as well. Just back to the chat here. This is an issue that has come up a lot in my work too, in relation to another public health crisis that's happening right now, which is the opioid overdose crisis. So this comment, it seems in BC that the increased opioid deaths in 2020, an approximate 75% increase, is very similar to the number of people that have actually died from COVID-19 in this province. Since there are relatively few deaths from COVID-19 for people under 60 in BC, it seems that the mental health impacts for people under 60 is much greater than death from actual infection. That's a very, very big question. Just turn it over to anybody on the panel who would like to comment on that.
Sorry, we don't ask a lot about substance abuse. We did originally. We stopped because I'm aware the commission has been doing work with CCSA, which they released a few weeks ago, which looked a little more specifically at substance abuse and opioids. But from our end, we don't have anything on that.
Thanks, Michael. Bonnie, did you want to make a comment?
Just to till towards the year, so much is occurring so rapidly in terms of the kind of domino ripple effects of all of this, and the ways that we direct our attention to, personal protective equipment and, physical distancing and, all that stuff. And just the consequences that the other presenters have captured through their survey responses. There's just, there's so much going on here. I don't know how many decades and centuries it's going to take us to work through this.
Yeah, it's very complicated and very complex. There's no doubt about it. Moving along in the chat, I noticed that while seniors were less likely to report pre-existing mental health conditions, a high proportion of seniors reported having unmet mental health needs. Approximately 75% of those with pre-existing conditions reported unmet needs. Correct me if I'm wrong. This is higher than the proportion of young people. So I believe, was that Brianna and Theone? Was that your study?
I suspect that it was, and I think that might be a misunderstanding of the way that those graphs were presented. So I apologize if it was confusing. But the orange bar in that graph was the number who had the unmet need. So in fact, it's between 5 and 10% of people with a mental health condition who report an unmet need for most age groups, and it's over 10% only in the 18 to 24, and then just over 10% actually in the 55 to 64-year-old age group. So fortunately, we don't have any group who's saying 75% have not had any kind of services to support their mental health needs. And it does seem to be generally lower in the older Canadians who have unmet needs.
Great, thanks for clarifying that. Another question for Brianna and Theone. Nice presentation, interesting and evolving results. Any comments a bit more on the representativeness? For example, socioeconomic position, family type. Is your survey representative for sub-Canadian analysis, for example, at the provincial level? So I think there's a couple of questions embedded in that one.
So I can tackle that one a little bit. In terms of representativeness, so the way that we constructed our survey, we had set recruitment targets by province, age, and sex. So we should have generally representative samples per province in terms of age and sex distributions. We didn't set particular targets in terms of social economic position. And I suspect that it being an online survey, there's certainly groups that we wouldn't have captured in our survey. People who have inconsistent internet access, people who are precariously housed, or who are unhoused may have had a much more difficult time accessing this survey. So I suspect that our sample may not be representative of some of those groups, but we do have information about family type, and that's something that I think we've been able to capture pretty well in terms of the number of respondents who had children living at home, children in school, children who are virtually attending virtual school, et cetera. So that's something, again, I think that we'll continue to explore in some of our additional analyses.
Great, thank you. Okay, I'm looking at the time. We have 1 minute left. There are a few comments in the chat box for our presenters for people looking to make connections. So I encourage you to just quickly scan those. There may be some people you would like to follow up with. I'm going to just scroll through here and pick one more question. And the question I've just landed on is, does anyone know about the mental health impacts on children? Are children included in any of the surveys or in any of the studies that we've heard about today?
I can tell you that we, because of the privacy and the way our methodology, we can't. That being said, I'm aware of a multi-university study that is, I know Nazim was on this call and he was talking to me about it. There's a few researchers who were on this call who were involved in that project. It's not ours, but there is a multiple university study going on. There's also one at CAMH with Joanne Henderson, who's looking specifically not on a population level, but has been looking on those who are existing clients of CAMH. I'm aware of those too.
Thanks so much, Michael. Bonnie, important discussion going forward about mental health and COVID-19. I'm not sure if there's any final comments from CanCOVID team. That's it for me though. Thank you so much, everyone.